Dr. Brian Kaufman, I doctor turned a patient with CLL on the last day of ASH 2013 with Dr. John Byrd. You want to just briefly introduce yourself, Dr. Byrd?
Yeah, I'm Dr. John Byrd. I'm a professor of medicine, medicinal chemistry, and director of the Division of Hematology at Ohio State University Comprehensive Cancer Center.
So we were talking about some new classes of meds and some of the industry issues in getting those meds. But there are a couple new medications that are coming up, and it looks like they're, there's a good chance that if everything goes well, that they're going to be part of the future treatment. So can you talk to us about what excited you in terms of the papers you heard?
Yeah, so there were, there was some old updated data that we'll talk about, but let's talk about the new things first. IPI-145, which is a P110 delta gamma inhibitor, which
is different than idelalisib, which is just the
delta,
and
right.
This has got the gamma, which is on the lymphocytes too, right?
Right. It affects more T cells, but we know that there's more and more information that the T cells may contribute to driving the CLL, and so
I just got to stop there because I just saw a paper on the activity of cyclosporin, which I'm on
right.
for. And it seems like its anti-leukemic effect seems to be T cell, kind of an indirect, which is what I always thought. But it was nice to see a paper that said, it really does have an anti-leukemic effect through the T cell mechanism. And it's so it's all this interplay, no cell is an island,
right. No, and so and that's, as we've seen the results that have come forth from IPI-145, and at this meeting. Dr. Flynn presented, updated results from the phase 1b, where they looked at two doses, 25 milligrams, and then the 75 milligrams, which is the PLC, which is the dose that inhibits both delta and gamma. The lower dose, it's very similar to idelalisib, and the response, in both arms in terms of shrinking nodes, was about 80%. With this drug, just like with GS1101 or idelalisib, you see the lymphocytosis. So your overall, that brought the overall response down to the 40s, because some patients had persistent lymphocytosis. What was interesting about the data that was presented, that there wasn't a difference between the high and the low dose, although it looked like there was more, although they didn't compare it carefully. It looked like there was more neutropenia and other side effects with the higher dose, and so they've decided to move forward with the lower dose. Thus far, the responses on this have been durable, and it's without comparing directly, it's hard to say if one thing is better or not. But certainly, it looked as good, and the fact that the lymphocyte count dropped in more patients earlier. It certainly is encouraging with IPI-145. The side effects of this were pretty manageable. Liver function abnormalities, which were reversible if you stopped the medicine and lowered the dose.
And then you could re-challenge them.
And there were a few cases of colitis, of rash. Again, there was also in that study a presentation of 15 patients who had previously untreated CLL, high risk, or were over the age of 65. And the response was low thus far, but the follow-up was very short. And so we'll have to see how this works in the untreated setting. I think that's still an open question. The other.
Let me just ask you these atypical pneumonias that's been seen with idelalisib in a few cases. Was this seen with the IPI?
Yeah, there were some infections. There were not interstitial pneumonitis, which has been seen, not commonly, but with idelalisib, and which is probably a drug toxicity. The number of IPI patients treated thus far is small, so that could show up with more patients being treated. The other molecule that was here that was new is ONO-4059 has a new BTK inhibitor, and it's unclear how this differs biochemically from ibrutinib. It
Because
certainly
it binds at the same site.
it binds at the same site, and in the presentation, the authors really did provide a lot of detail about the selectivity profile relative to ibrutinib. But what I would summarize the data. It's a BTK inhibitor that's taken daily. It has a little bit better bioavailability. So by that, with that, you would expect at the lower doses you would see, you may see more efficacy than say. Whereas with an agent that has lower bioavailability, if you have to start at a real low dose, you're probably not going to see. You're less likely to see efficacy. So the study showed results that were, I would say, were very, very similar to ibrutinib. I've heard some people walking around the meeting saying, well, the results maybe are better, but I think it's all in sort of the patients coming into the trial. The patients coming into this trial had a platelet count, had an average platelet count above 100 and an average hemoglobin above 11. So that tells us, that a lot of them were earlier stage patients, and so it looked interesting. It looked at least as good. I had a hard time telling it was different than ibrutinib. And for the patients though, if we have several of these that are going through clinical trials and get approved, even if one is not much better than the other, it offers the advantage of competition, which in the end will hopefully bring down the price of these and make them more available. Because I think that's going to be a big issue as these agents get approved for older patients or younger patients that the co-pays that they're going to have to pay to be on these medicines. There was.
Let's hold on that, and we'll look at the maybe some monoclonal antibodies and some other things in the next segment here. There's just one thing that I think is interesting, and that's with the ONO drug, is the whether or not it is more selective, and whether or not that's a good thing, because I've heard that they may have less activity against APK and a couple of other things, but maybe that's not a good thing. We don't know yet. So yeah.
Well, the mouse models would suggest that BTK is probably the right target. And there's been a lot of concern that being too selective is not good based upon the experience with CC292, the cell gene molecule, and that may just be a drug problem. It may not be the selectivity, and so I think we'll learn that as there are other new BTK inhibitors that are about to enter the clinic that are more selective in addition to the ONO molecule. So we'll see as more data emerges.
All right, so let's hold there and we'll come back in a minute. Thanks.
All right, yeah.